Story. Apparently, our moderator is moderately late today, so I am forced to start the lecture before the moderator gets here so we can cover as much ground as possible in the subject assigned for tonight, that is the physiological aspect of sex. As you know, in sexual behavior, there are two basic factors that we have to consider. One of them are physiological, the other are psychological. We are going to study then today the substratum, biologically speaking, of the sexual behavior in the human being. The psychological aspects that are as important, if not more important, in the sexual behavior of the human being will be covered in the lecture of Dr. Scher. I had to make a special emphasis in the fact that the psychological factors in human sexual behavior are very important, so much that there are reasons to believe that the sexual behavior of the human being are mostly a result of the cultural environment and mostly learned. Nevertheless, the same way that we cannot understand thinking without having a knowledge of the central nervous system, we cannot understand the psychological aspect of sexual behavior without a knowledge, at least basic, of the biological substratum of the human being in the parts that are related to sexual behavior. So we are going to start precisely with that. Before going into the physiological aspect of sexual behavior, there is a tendency right now, precisely because of this interplay of the psychological and the physiological factors, to divide the study of the sexual behavior in the study of sex and what it is called gender. Now, sex is mostly identified in this type of approach with the biological factor. And the words that we use in this related approach to sex are, as you know, male and female. Now, the gender is the psychological side, and we understand for gender the sex to which the individual identifies himself with. The gender is the sex that the person believes it has, independent and sometimes in conflict with the biological factors. And in gender, that is the psychological or cultural factor, the terms related to this as equivalent of male and female will be masculine and feminine. And this is the reason that when we are talking about a person, we can talk about her masculinity or her femininity without implying is we are talking about a female or we are talking about a male. And then in the study of the gender, we have a gender roles, gender attitude, and so forth. Just to put an example about the difference between the biological factors and the psychocultural factors in sex, we have what this was mentioned the last time here about people that change sex by surgery. Well, so some people may be, biologically speaking, a male, and maybe psychologically speaking, belong to the feminine. And for all practical purposes, these persons feel as a female in the sexual sphere. And then when we have this dissociation between the male, biologically speaking, and female, psychologically speaking, these people feel exactly like a female that is trapped in the body of a male. And this is the reason that the doctors and the psychiatrists and psychologists agree that these people should have corrective surgery to make their biological makeup as close as possible with the gender or the role or the sexual role that these people feel and are identified with in sex. So this is just a specific opening clarification of what we call sex and what is gender. And as I said, Dr. Sher and she will have a lot to say about this type of factors as opposed to the biological factors about which we are going to talk today. Normally, in the human being, you know about the facts of life, I used to say, that the sex of the person is usually or normally defined since the fertilization of the ova takes place in the genital organs of the female of the species. Now we know that in the human being there are 46 chromosomes, and these chromosomes we divide. There are 22 pairs of leptosomes or chromosomes, and then there is one that we call the sex chromosome. Now, there are two kinds of sex chromosomes in the human being. One is the so-called X chromosome, and the other is the Y chromosome. When the ovum from the female and the sperm from the male get together for fertilization of the ovum, the female usually has an X chromosome plus the 22 of the half chromosome that belong to one of them. Now, the male has the 22 chromosomes plus a Y or an X chromosome. Now, if the sperm that fertilizes the ovum is a Y chromosome, then we will have 44 chromosomes plus the combination X, Y, and this combination will give a genetical sex that is male. If the combination is with another X, then we will have the 44 chromosomes plus 2X sex chromosome, and then this is the genetical brand of the female. So, since the moment of conception, when the ova is fertilized in the uterus of the woman, we have that in that moment, the combination of chromosomes made the product of conception a male or a female, depending on the combination of the sex chromosomes. If we had two X chromosomes, the individual is genetically speaking a female. If we have an X and a Y chromosome, then the individual is genetically speaking a male. Now, at the beginning, for the first 6 weeks after conception, and you know that the conception from conception to delivery usually is about 9 months. In the first 6 weeks of conception, there is no way to tell if the embryo is a male or a female, because up to that moment, the potentiality of the germ cells to be a ovary or to be a teste aren't manifested yet to the examination that you can do with a microscope if the fetus, if the embryo were dead or for some reason you get it out. So from 6 weeks after conception, there is no way still to tell if the embryo is a male or a female. After 6 weeks, it is possible to see some of the characteristics of the male or female. There will be some tissue that will be a ovary, or there will be some tissue that will be a teste, but it still will be difficult, and usually it's after the 10 weeks after conception that we can be sure that we are dealing with an embryo that is a male or a female. After this, the conception advance, the genitalia develop in the human male will be the penis, the scrotum, the testes, the prostate, and so forth. In the female, we will have the uterus, the ovaries, the fallopian tubes, and so forth. So much that when the delivery time comes, usually the doctor, the mother, and the relative have no problem in stating that it's a boy or it is a girl. We are talking now about the usual case, because there are many cases that we will consider in our next lecture, in which there are pathological developments, in which sometimes external genitalia that can be taken as belonging to a woman may belong to a male, and vice versa. But usually we can be sure that this is a boy or this is a girl, to the pleasure or disappointment of the fathers. Nature doesn't care too much about that. And you have to remember that the human being is the result of many, many millions of evolution. Therefore, a very adequate prospect to be successful in the environment. Now we continue with the development of this child now. And usually the sexual part will be kind of sleeping, just keeping themselves growing at the same step that the rest of the body. And usually there is not too much to distinguish between the girl and the boy, except the external genitalia. But the face, the body habit, and so forth are very much alike until we get the time of the puberty. That usually is around the 13 years or 12 or 13 years for the female, and about 1 or 2 years later for the male. The female in our species mature earlier than the male. Now, what happened at that time? Well, at that time, what happened, as you know, is that the secondary sexual characteristics start to develop. First, there is a growth of the external sexual characteristic like the vulva, the vagina. There is a growth of the uterus. There is a growth of the ovaries. Then the things that we can see mostly is that the female will develop some fat in the hip and in the upper thigh. The breast that was flat like a boy will start getting up in most of them anyway. And at the same time, parallel with this development, there will be some psychosexual changes, like more feminine attitude that will be touched by Dr. Sher in the genre part of the lecture. Now, in the male, I say this puberty start about 2 years later than in the female. We have the enlargement of the penis, the testes are getting bigger too. Then there is, like in the female, presence of pubic hair. And there is a difference in the shape of the pubic hair in the male and in the female. In the female, the pubic hair is usually as a triangle with the base upward. In man, the pubic hair is mostly a diamond-shaped type that goes from the umbilicus to the sides of the pubis and down to the penis. Then we have the development of hair in the chins and in the upper lips. The voice get kind of deep because of the enlargement of the larynx, and it starts acquiring this asthenic build with muscles very different from the female. Then after that, the female starts the menstrual cycle until there is a time that the ovary doesn't have any more ova to give, and then the woman around 45 or 50 goes into the chain of life, the menopause, and this is the end of the reproductive period of the woman, biologically speaking. And then after this, the chain of life, she will continue not having any more period, and there will be some atrophy usually of the secondary sexual characteristics. Some girls will develop some hair in the chin and they will lose some of their fat, although usually the tendency is to gain fat, and there will be some psychological changes paralleling these two. In the female, in the same way that the puberty is 2 years later than in the male, in the male the puberty is about 2 years later than in the female, and the climaterium, the chain of life, usually is very late to around 60 or 70 years old. And most of the males go without any symptom, although some of them become irritable and mostly depressed because of the declining of the sexual potentialities in the male. So up to now, we have gotten a very quick look at the sexual description of the male in a longitudinal sequence from conception to after the reproductive period in the woman and in the climaterium in the male. And then we have to ask ourselves what is happening inside the human body while these changes are mirroring outside the changes inside. What is motivating this suddenly development of the sexual biological characteristic in the male or female? What is producing this menstrual cycle that every 28 days the woman bleeds for about 5 days, and then this goes on and on until she gets pregnant, until the chain of life comes. And this is precisely what we are going to do now. We are going to get a close look from inside, from the physiological viewpoint, at the changes that are motivating these changes in the surface of the body in relation to the sexual characteristics. And in the human being, the sexual cycle and the sexual changes are under the control of the endocrine system. The endocrine system is a group of glands that has no outlet, no duct for their secretion, and they have to put the secretion directly into the blood, and this is the reason that it's called endocrine glands. The common endocrine glands are the hypophysis, that is the one that usually control our endocrine system, the thyroid, the ovaries, the suprarenal glands, and so forth. Now, for the sexual part, we are mostly interested in two components of this endocrine system, and they are the hypophysis and the ovary. It will be mostly under the control of the hypophysis and the harmony of functioning of the hypophysis with the ovary that all these changes at this cycle will take place in the human being. We are going to start studying these type of cycles in the female because they are more complicated, they are more important for contraception and the study of the pill and so forth. And once you grasp the fundamental of this harmony between the ovary and the hypophysis, probably you can harmonize your psychological character better, knowing that some of the changes in your mood may be due to these hormonal changes that are going inside in the body. And then the hypophysis is a gland that is in the base of the brain. The hypophysis is divided usually between the anterior, the posterior hypophysis, and there is a pars media that doesn't have too much importance in male or female, but it's important in some animal species. Now, the anterior part, the anterior hypophysis, is the one that is directly related to the sexual development of the female and the male. Now, in the female, we have the hypophysis, and we have here, let's say, the ovary. And I say before the puberty, before the 12 or 13 years of age, there is no way that we can find any sexual hormones coming from the hypophysis to the ovary, and there is no hormone from the ovary that we can detect before puberty. This doesn't mean that there are no sexual hormones in the human being before puberty, but we believe that what happened is that the level of the hormones in the blood and in the urine are so low that our method actually to pick up this or titrate this hormone are too rough to pick up this small amount that there must be circulating of ovarian hormone and hypophysis hormone. But then suddenly, when the puberty comes, there is a awakening of the hypophysis. And the hypophysis will produce two types of hormones that will be directly related to the menstrual cycle in the female. One is what we call the folliculo-stimulant hormone, and the other one is the luteinizing hormone or lutein hormone. Now, I will put down here the way that the cycle goes so we can correlate the different level of hormone with the cycle in the female. So we start here. Let's say that we have the menstruation. And in the average, the menstruation for the first day will take an average of 5 days. And we will start calling number 1 the first day that the female starts menstruating. Then after the menstruation, in the 14 days, will be what we call the ovulation, and then we'll have the 28th day, and again, the cycle will start again with the menstruation. Now, the ovary produce, under the influence of the follicular stimulant hormone, produce two type of hormones. One is estrogen, and the other one is progesterone. Now, the cycle goes like this. The first thing that happens during the menstruation, there is a very low level, if any, in the blood of follicular stimulant hormone, luteinizing hormone, estrogen, or progesterone. The level is almost so low that we can't really pick it up with confidence to say that there is any level. Then, right after the menstruation, then the follicular stimulant hormone, let's say that this is the base level, will start going like this, and then there is a sharp rise of the follicular stimulant hormone in the 14th day. The luteinizing hormone had exactly the same type of cycle. It starts rising a little later and then goes down. Now, the follicular stimulant hormone will produce in the ovary the maturation of a follicle. And that is the reason that we call it follicle stimulant hormone, because it will stimulate a follicle to mature. For this we mean that this follicle will start getting bigger under the influence of the follicular stimulant hormone, and at the same time that there is a maturation of the follicle under the influence of the same hormone, the ovary will start producing estrogens. And estrogen will go like this. It will have a sharp rise in the 14 days, then go down, and then again goes up about the 21, 24 days. And then goes down to almost nothing. Now, from this moment, from the menstruation up to here, that is the ovulation, the changes that we are going to see in the ovary due to the follicular stimulant hormone and some luteinizing hormone will be that this follicle will be getting out till it reach the periphery of the ovary. And in that moment, it will rupture here, and there will be a ova here that will get out, and this is what we call the ovulation that is produced precisely in the 14th day of the menstrual cycle. Now, this ovulation here produce in some people, produce pain, and in the health service here of the college, I am very familiar with girls that come precisely 2 weeks after their menstruation complaining of abdominal pain, and precisely what has happened to them, and sometimes we have some blood, is the fact that they have had a painful ovulation, and it is called Mittelschmerz. But sometimes, usually the female doesn't know that has ovulated, but some, a 25% had this pain or some kind of abdominal cramps precisely in the middle between 2 menstrual periods. Now, once this ovulation has taken place, this is the female ovum that can be fertilized by the sperm, which means that the time in which the female can be fertilized by the male sperm is in the ovulation. Now, this ovum usually can be fertilized only between 24 or 36 hours, because after that it isn't able, because it is destroyed by some of the humors in the organism. And the same in the vagina of the woman, the life of the sperm is about 24 to 48 hours at the most, which means that this is the time that is optimum for fertilization of the female by the male. Now, at the same time that this is happening in the ovary, in the uterus, this happens. During the menstruation, most of the internal side of the uterus is washed out because of the necrosis in the blood and the tissue. And then under the influence of the estrogens, the wall of the internal side of the uterus start increasing. And this is what we call the proliferative phase of the uterus. The inside of the uterus start getting rich again in blood vessels, in tissue, in proteins, and so forth, getting ready for the ovum that is produced during the ovulation. Now, after the ovulation takes place, then the inside or the place that the ovum was, that is what we call the follicle, the Graafian follicle. There is some degeneration of some cells here that we call the theca interna, the name doesn't matter, and it's called the corpus luteum because it's kind of yellowish. And this yellowish corpus luteum is the one that is going to produce the hormone of pregnancy, that is the progesterone. And then it will start producing progesterone, and the progesterone will go up like this, and you fall down just before the next menstruation. Now, under the action of the estrogens, as you can see, the wall inside the uterus start getting larger and richer again in proteins and nutritive substance, getting ready for the ovulation. And after the ovulation is produced, then under the action of the estrogen and the progesterone, it's getting even richer. And then, if there is no fertilization, if there is no pregnancy, then when these two hormones, the estrogen and the progesterone, and the follicular stimulant hormone and the luteinizing hormone, all of them, at the moment here, they reach a value close to 0, and then this mucosa inside the uterus that was ready to receive the fertilized ovum will start again being washed out from inside the uterus because of the deprivation of these hormones that are the ones that have produced this change inside the uterus. And then in the menstruation, we had the loss of some tissue, about 50 cc of blood in the 4 or 5 days, that is the average term. And then the body again start getting ready once more to produce another ovum and to have the ovulation and to be fertilized. And until there is a fertilization, this cycle will continue producing until the female reach the chain of life, the menopause, in which the ovary will be depleted of all the Graafian follicles, and therefore there will be no more production of progesterone or estrogen from the ovary. And then due to this, the secondary sexual characteristic after the chain of life may change. The voice may get kind of deep in the female, she may get some hair, and so forth. But let's get a closer look at this, because at the same time that we had this menstrual cycle, we have to understand how the fertilization takes place. And for this we will need a minimum anatomy of the female genitals. Let's say that this is the vagina. Then we will have here the uterus. And then inside of the uterus we have the fallopian tubes. And then here we will have the ovaries. And then this is the vagina. This is the cervix, the tip of the cervix. This is the body of the uterus. These are the fallopian tubes. And here is the ovary. Now, in the first part, as you can see, there are two things going at the same time. One is the maturation of the follicle that is getting bigger and going to the surface. And the other one is that this uterus, that the inside part has been washed out in the menstruation, start getting thicker, getting more vascularization, more proteins, and so forth. Then, in the moment in which the ovulation is going to be produced in the 14 days, then the ovum has reached the periphery of the ovary, and the ovum here is extruded, and this part of the fallopian tube, the fimbria, seems to look for it and grab it, and then this ovum starts going in this way to the uterus. Usually, in going this way, the ovum spends between usually about 2 or 3 days, and if the female is going to be pregnant, usually the pregnancy will be someplace around the middle third of the fallopian tube, which means that the sperm of the male has to go into the uterus and then go for the fallopian tube, and then fertilize the ovum in the fallopian tube. Once the fertilization is done, then, as you can see here, the estrogen and the progesterone that is being produced here by the corpus luteum continue getting the inside of the uterus ready for the implantation of this ovum. And then around the 20 or 21 day of the cycle, if the ovum has been fertilized, it will come and it will be implanted in the inside of the uterus, what we call the endometrium, which it will be ready to receive it. But if there is no fertilization, then the ovum continue the trip to the uterus. When it gets here, without being fertilized, it will lose its power to be fertilized, and then at the 28 days, it will be washed out with the rest of the endometrium of the uterus that hasn't been fertilized. So as you can see, the important thing here is, in first place, that we need a functioning hypophysis that can stimulate with the follicular stimulant hormone and the luteinizing hormone the ovary to produce the ovum or the ovulation, and to produce the estrogen and then the progesterone with the corpus luteum. If you don't have ovaries, then the person is sterile because there is no production of ova. And even if we have a good functioning hormone hypophysis, there are no seem to be stimulated. Therefore, these people is sterile and doesn't have any cycle. Then the same, if you have a person that has some disease in the hypophysis, then they will have disturbance in the cycle because of lack of the follicular stimulant hormone and the lutetropic hormone. Now, so the fertilization of the female depends first in the presence of a ovum in the uterus or in the fallopian tube. Second, the accessibility of this ovum to a sperm, male sperm, to be fertilized. And then, once, let's say that instead of not being fertilized, the woman is fertilized. What happened then? She's pregnant. Then, what happened is that this pattern, that the progesterone and the estrogens go down, doesn't happen, and it's the other way around. The titers keep going up and up, and this corpus luteum that usually will disappear at the end of the cycle because lack of stimulation from the luteinizing hormone get bigger and bigger and will produce progesterone, that is the hormone of pregnancy, at high level for about 3 months to avoid the uterus to drop this egg. And then 3 months later, there is a special formation that is the placenta in the person that is pregnant, and this placenta will produce great amount of progesterone and will keep the pregnancy going until the time that is ready for delivery. We have a monocycle in the pregnant woman that will last 9 months, and that is a cycle that will repeat itself when the woman gets pregnant again. Now you can see what is the rationale in general in the anticonceptive use of the so-called pill. Usually the pill is a combination of estrogen and progesterone, and this combination is given from the 5 days to the 25 days, because you take one pill 1 day for 20 days, and what you are taking is estrogen and progesterone. And this high level of estrogen and progesterone will produce a lack of ovulation. Just exactly what happened when the person is pregnant. When the person is pregnant, the high level of estrogen and progesterone will stop any maturation of the follicle and any ovulation until the pregnancy is through. Now, in the woman taking the pills, you produce a pseudo-pregnancy state with high level of progesterone and estrogen, and then the bleeding that the woman taking the pill has is not exactly a menstrual bleeding, but it's what we call a deprivation bleeding that is due only to the fact that the levels of the hormone suddenly goes down and then they bleed. And this, for example, happens when you have, for example, a little girl that is born. In the little girl, she has in the blood high estrogens and high progesterone because she's taking this hormone from the mother that is pregnant. Now, after she's born, she lost suddenly this estrogen and progesterone level, and then it's very common that after 1 or 2 days after they are delivered, the little girl will have a bleeding from the vagina. And all this bleeding is just due to the deprivation of the progesterone and the estrogen in the blood of this little girl. So in the woman that is taking the pills, there are high level of progesterone and estrogen for about 25 days of this cycle, and then the bleeding that is produced is deprivation of these 2 hormones level when you stop taking the pills, and then there is no ovulation because the high level of estrogen and progesterone will inhibit the production of this follicular stimulating hormone and the luteinizing hormone, and therefore there will be no ovulation. So the bleeding that the woman taking the pill has is anovulatory. We say that the menstruation is the burial of a ovum that wasn't fertilized. Well, in the woman that is taking the pill, there is no burial. It's just bleeding from the deprivation of the hormones. Now, when the woman goes to the puberty, and the first sign of puberty is the development of the first menstrual bleeding, usually between the 12 to the 14 or 15 years of age, most of the menstrual cycle are anovulatory. There is no ovulation usually in most of the cycle of the woman between the 12 and the 14 years of age, and they are mostly due to the level of hormones like this, but there are no eggs to be fertilized in most of this cycle. So they are very much like the cycle that the woman taking the pills, the anticonceptive pills, has, in that there is bleeding, but there is no ovulation, and therefore there is no chance that they can be pregnant at this stage. Then when the menopause comes, and they usually mean that the ovary is depleted of the Diaphragm follicles, then there is no more menstrual bleeding, and this level of estrogen and progesterone almost disappear because the ovary is unable to produce them anymore. But then the anterior hypophysis, this is kind of a feedback mechanism that the high level of this hormone will produce inhibition of this, and low level of this will produce increased stimulation. And then what happens is that the follicular stimulant hormone and the luteinizing hormone, when they lose this break, that is the feedback mechanism, will be producing increasing amounts, and that is the reason that in women that are after the menopause, you can recover in the urine a very high level of the two gonadotropins, that is the name that we give to the stimulant hormones from the anterior of the hypophysis. Then another interesting thing is the fact that these two hormones, the estrogen and the progesterone, retain in the body of the female water and retain sodium usually. And that's the reason that you will see that many times some of the girls, just before their period, they will complain that they gain some weight, and some will complain that they have headache, and it's because of this high amount of estrogen and progesterone that there is a retention of salt and there is a retention of water. Now, this retention of water is not only in the body tissue but also in the brain, and this is one of the reasons that many of the girls will complain of headache because of this increased amount of salt or sodium and water in the tissue. And this is the rationale why some of the girls that come to see me at the health service, because of what we call premenstrual tension, we usually give them a diuretic that will get rid of this excess of water and this excess of sodium, and this usually help them quite a bit. Then I say another important thing is that sometimes this ovulation in the 14th day may be painful and may be sometimes accompanied even by some bleeding in very few cases. What else is interesting to know about this? Well, the progesterone, one of the qualities of the progesterone is that usually increase what we call the basal temperature of the person, which means that if a woman take her temp with a thermometer every day during the cycle, usually it will stay stable like this, and then suddenly it will go a little down, and then goes up, and then stay up until the menstruation comes and then start down. And this is the action precisely usually of the progesterone and the estrogen that I say they increase suddenly. Is a sharp rise in the ovulation period. And this is one of the anticonceptive methods used, that the woman takes his temperature every morning, and then when there is a sharp decline and up, then this indicates the ovulation, and they should avoid, they don't want to get pregnant, any sexual intercourse at this time. The problem with this is that it's not very reliable. Usually this change can happen 2 or 3 days before or after the ovulation, so only you want to play Russian roulette, it's it's better to recur to other type of anticonceptive system. Then you have here about the rhythm system, and what they do usually is to tell the person that counting for the first day of the menstrual period, to count 10 days, and then another 10 days, that will be 20, and then not to have any occasion for pregnancy between the 10th and the 20th day. Just take in consideration that the average, the ovulation takes place between these two periods. Unhappily, nature is not as regular as we would like to believe that she is, and there are many exceptions to this rule. And again, this system is not very reliable. You can get into trouble if you want to apply it mathematically. It is defiant. It is completely beyond the power of the computers, even to try this type of problems in this way. Now, is there any relationship? This is another interesting question. Is there any relationship between the sexual desire or sexual drive and the cycle, as we have put it here, in relation to the hormone picture? Well, there are not many studies about this, but there seems to be evidence that there are a increase, if we say this is sexual drive, there seems to be an increase in the sexual drive in the time of ovulation, and then again before, during, and little after the menstruation. Now, apparently, this peak that hasn't been very well documented by all the studies, it will very well fit with the ovulation and the survival of the species. Now, this part here has been explained by the fact that in our society, most of the people, since that it's taboo, sexual intercourse during menstruation, and then this increase, they believe, some people believe that it's due to the fact that they are thinking about the deprivation period that is coming, and then after the menstruation is gone, that this is probably due to the abstinence that they have been forced by the taboo of our society. I say these are interpretations. The facts are only there seems to be an increase in sexual desire or drive just before, during, and after the menstruation, and a small increase during the ovulation period. Now, before I continue, I would like to know if there are any questions about this. As you can see, I have been touched just in the normal part because I'm leaving the abnormal for the next lecture. Are there any questions about this? Yes?
If a woman is taking the pill, and will her change of life come later because she has more eggs to get rid of?
There are no studies about this, but the general belief is that doesn't change. It doesn't make it sooner and doesn't make it later. It just comes in the right time. If there is a right time for that. Yes.
When a woman is on a pill, does the decrease of estrogen and progesterone in the bloodstream during the time, or just before the time of menstruation, produce possibly a release of an egg at the same time?
No.
It's not possible.
No, because for an egg to be released, it has to be mature. And the maturation of the egg takes 2 weeks. Any other question? Yes.
Are there harmful effects that the pill causes, like blood clotting?
Yes. Well, this is still a debatable subject. There are 2 things about the pill. One is what we call the side effects, and it's what we would expect because of the action of the increased progesterone and estrogen. And this is mostly people that has now, I say, the pill produces a pseudo-pregnancy state. So some of these people had the problem that pregnant woman has in the first 3 months, nausea, vomiting, headaches, irritability. And these are side effects. And you may retain some water too. Some people complain and they can take it because they get so bloated up and the ankle gets swollen and so forth. These are side effects that we would expect in anybody, this is the normal action of the hormones, and this is the reason that 5% or 7% women cannot take the pill even they want to, they had to stop it. Now the pill have been incriminated mostly in that increase the risk of phlebitis, that is a clot in the legs, and therefore the complication that can come for this. Up to now, the general opinion is that there is no major incidence of phlebitis in women taking the pill than in women of the same age not taking the pill. But I think that we are seeing most of this in our practice, so it has to be kept in mind it's not a harmless type of medication by any means. Any other question? Yes?
Are you only supposed to take the pill for 2 years because it would decline fertility?
No. You can take it for many years. Not only fertility usually don't decline, but there is what we call the rebound phenomenon. If you stop it, you are more likely to get pregnant than you weren't taking them before. So this is something to keep in mind too. Any other question? Yes.
Is it true that there are different types, different people have different types of pills?
What do you mean?
It's only not one type of pill.
No, there are different types of pill in the market, but all of them are basically the same thing. A combination of estrogen and progesterone, and there are some that has a little of androgen. And I say the different in composition, but they are basically the same thing, and this is a matter of, it's a matter of dosage. Some people need a stronger dosage, some people need less, some people can't take any. Any other questions about this specifically?
Do you have any good studies of long-term usage of pill?
Yeah, there are 10 years studies.
Are there any that are dramatic?
No. Yeah, the pill have been used in some studies for 10 years without any serious complication. And the pills are considered right now for the authorities in gynecology and obstetricia to be 100% effective. The few cases that have been reported in which there has been pregnancy in further investigation have been found out to be that the woman forgot to take the pill. And now we will go to the analysis of the human sexual response. As you know, because of the secrecy and the attitude of Western civilization to sexuality, the study of the human sexual response have been kind of lagging behind the studies almost in any other area of human physiology. Nevertheless, there is an excellent study that was done not long ago by Masters and Johnson precisely about the human sexual response. In this study, this practicing obstetrician, they have subjects, male and female, engaged in different types of sexual activities, and they did record their responses. They took movies. They used to stimulate the woman artificial penis through which they could take movies to see the changes in the vagina, and they record the electroencephalogram, electrocardiogram, temperature, and it's a very well documented study, and most of it have been confirmed later on by further studies, although there are not so many still. So most of the studies I'm going to do about the human sexual response are based really in the book Human Sexual Response by Johnson and Master. In first place, I had to explain that the human sexual response is the name given to this study because one of the findings of the authors is the fact that the human being responds to sexual stimulation organically or psychologically in the same way. There may be some difference in degree, but in general, it doesn't have to be sexual intercourse. It can be produced by petting the erogenous area, by stimulating the brain with images, and so forth. And apparently, human beings in these studies all respond in the same way, and that's the reason that they call it human sexual response. So what we are going to study now is what happened from the descriptive viewpoint inside the person that is responding sexually to a stimulation. And they found out that they could divide the human sexual response in 4 phases, and these phases, the division of these phases is mostly academically just to get some type of systematization in it, but there are no definite limits between one and the other because they blend into each other. And I say this is just the result of the average of their studies, and there are many, many variations, mostly in length and so forth, in relation to the sexual response. Now, they believe that the sexual response in the human being go to 4 phases, and then first we have the excitement phase, then second is what they call the plateau phase, then the orgasmic phase. Now, in the excitement phase, it will start in the moment in which an adequate stimulus for that human being start arousing the person sexually. Now, what are the main changes? And I say this can be brought either by playing with the breast, kissing, necking, petting, any stimulus that is adequate for the person that is under the stimulus. And then, what are the main changes that we get in these people? And then for the study of the changes, we will have changes in the sexual organ, changes in the breast, heart, lungs, skin. Well, they believe that from their studies in the excitement phase, the first thing that happens in the sexual organs is that the external genitalia become full of blood and engorged. There is erection of the clitoris. The uterus start getting engorged. The vagina start getting larger, mostly the two-third distal third. Then in the breast, the one that will show first the excitement phase will be the erection of the nipple. The heart will increase in rate, and this will depend on the type of foreplay that is being the excitement phase, and the same with the blood pressure that will start going up. Usually in the excitement phase there is no increase in the respiratory rhythm, and in the skin usually there is what they call the sexual flush, that is a reddish coloration of the skin that starts probably in the abdomen and starts spreading. Then in the plateau, here the first thing that happens to the clitoris is that after being engorged, it starts decreasing in size because it's covered by the hood or skin, and almost get the idea that it disappears. Then the characteristic of the plateau phase is what they call the platform. The external third of the vagina get engorged and get smaller, reducing the diameter, like if it were, how should I say, like if nature were to keep under control the penis if it were in the vagina. And this is what Master called the platform, the sexual platform, that is characteristic of the plateau. Then the heart continues increasing in rate and the blood pressure continues going up. At this stage, there is some dyspnea, there is increased respiratory movement. The skin, the sexual flush start extending farther to the thighs, to the arm, to the neck, and to the face. And then in this stage, usually the rectal sphincter start having some rhythmical contraction. Then in the orgasmic phase, and they usually last only for 4 to 10 seconds, in the female, the orgasm comes suddenly. The breast at this stage, not only the nipple but the whole areola is enlarged. The heart is very fast. This is the peak of the action of the heart and the blood pressure. There is a severe dyspnea, increase in respiration. The sexual flush is still in the skin, and the rectal sphincter continue contracting. Then, as soon as the orgasm is over, they go into the resolution phase, in which all these changes come back to the pre-excitement level in the female. Now, usually, there is a relationship between the excitement phase and the resolution phase. The longer the excitement phase is, the longer is the resolution phase. The plateau and the orgasmic phase are usually very fast and very short duration. Now, in the male, the changes in the skin, the change in the lungs, and the change in the heart are about the same. Now, in the sexual organs, the erection of the penis will substitute for the clitoris in the female, and the breast in the male, in 25% of them, it will become too engorged and erect, usually during the plateau phase and the orgasmic phase. Then another basic difference is the fact that in the male, the orgasm is marked by the ejaculation. In male, orgasm and ejaculation go together. Now, the ejaculation can be divided into two different phases. One is what we call the emission. That is when the semen goes to the urethra, and then the ejaculation proper, when it is expelled from the urethra. One interesting thing is the fact that even if in male ejaculation and orgasm go together, this may be just a coincidental type of things, because, for example, in male that has an accident and they have a section of the central nervous system, the medulla, that it will completely crush the communication between the high brain and the lower center that is in charge of the reflex ejaculation. The individual still can ejaculate, but because of the lack of connection with the brain, it doesn't feel any orgasm. And this happens, for example, in people with paraplegia that have tumor of the lower medulla. They can have erection if they are stimulating locally, because this is a reflex, but they can have no orgasm, even if they have ejaculation. Then, another important thing is the fact that to go through all of this is not even necessary an external stimulus. The person can very well, with her own fantasy and imagination, go through all these four phases, and this happens, for example, in people that is sleeping and they wake up and they are wet, and they wonder what happened. Well, and there have been already speculation that maybe these people have some type of erotical dreams and so forth. Well, they have been documented a very interesting study. In the studies about dream, when you take the electroencephalogram, that is a tracing of the electrical activity of the heart, they found out that while people is sleeping, there were two types of patterns in the electroencephalogram. One was what you can call the normal deep sleep, and then there was another part in which the individual has rapid eye movement, and they can be seen in the electroencephalogram. So they divide this the sleeping pattern from electroencephalography in rapid eye movement and non-rapid eye movement. And they, doing further studies, they found out that usually we don't sleep evenly, but we go from one sleep to the other, and they found out that about every 90 minutes, we go for half hour to the rapid eye movement, 90 minutes of non-eye movement, and then rapid eye movement again. Then in the laboratory, they start waking up these people as soon as they start fluttering the eyelids or the eyes, and they found out that these people was dreaming. Until after much study, they discovered that these people really was dreaming, and that when we are dreaming, we are having rapid eye movement. And when we are not dreaming, we are having the other type of sleep. Then they found out that some of these subjects that has ejaculation while sleeping, they always did have the ejaculation while the electroencephalogram showed that they were having rapid eye movement. And when they were wake up right away, they agreed that they were having erotical type of dream. So there is no question that the human sexuality can respond to many, many different type of stimulus that doesn't have to be necessarily sexual intercourse, but can be just fantasy, can be necking or petting, and so forth. So this is very important because it's a very well-known fact, for example, that women usually get the orgasm easier with a stimulation of for masturbation, for example. When male usually get the to go through all the phases of the human sexual response, mostly through sexual intercourse. So there are some differences indeed that are important to know because as we will see later, and I'm sure Dr. Sher will have a lot of things to say about this in marriage and so forth, these are important differences. Now, just a few details before we go to the questions. Can a girl get pregnant petting? Yes. The only condition to get pregnant is the junction of the ovum and the sperm in the female organ. So if somebody has a semen in the finger or something, any way that can get to the vagina can produce a pregnancy. Then another question, I was trying to remember the question that you asked me the last time. Another question that I got was, in a person that has a vasectomy, and this means sterilizing somebody, tying the vas deferens in male, is there any danger of getting pregnant? Yes. Part of the semen is stored in man in the seminal vesicles, and these are after the level that we tie usually vas deferens in vasectomy. So for the first 2 or 3 days, anybody who has a vasectomy can get somebody pregnant because of this storage of semen in the seminal vesicles. Then another thing is that one of the methods of birth control or contraception is the withdrawal of the penis before ejaculation. Does this work and it is safe? Well, some of the studies have demonstrated that even before the ejaculation, there is sometimes emission of the seminal fluid that may have sperm. So this is not a 100% safe procedure, organically or psychologically, I think. Are there any other questions now?
Dr. Could you use your diagram and show them how the interuterine device works?
Yeah. One of the methods of anticonception is what we call the intrauterine device. Now, the intrauterine device, I will go briefly over the anatomy of the uterus. The uterus is divided in what we call the body of the uterus and the cervix. And as you can see, part of the cervix is inside the upper third of the vagina. Now, if the sperm is going to fertilize the ovum in the uterus, it has to go through the cervix, and this is what we call the external os, and then here the internal os, and go inside the uterus to fertilize the ovum. So anything that can block the entrance to the uterus, it will be an effective contraceptive. And this is what the intrauterine contraceptive device are, and the most common one right now is the one that they call it's a device that has a plate here, and then there is a coil here. And this is a very safe device. Most of the gynecologists that I talk about, they believe that this gives a protection close to 100% or at least 98% when it is properly applied. Now, these anticonceptive devices are of two kinds. There are some that are plastic, there are some that are metal. The tendency right now is to use the plastic ones. Now, one of the things is that the anticonceptive device has to be fit by a properly trained physician to be sure that it's right for the dimension of the cervix of the woman that is having it and that is placed properly. Now, as you can see, this anticonceptive device has to come out during the menstrual period. And usually the physician can instruct the woman to put it on and to take it out, and they can become very proficient in this. The disadvantages are, first, and I say it's not completely safe, it's about 98-99%. Second, there is a question about damage to the cervix, that is the most common place of cancer in the woman. So this may produce a small ulcer. So these people have to be supervised very often to be sure that they are not developing anything. Then there have been some complications in which the anticonceptive device has gone inside the uterus, and sometimes these people have had to have surgery to get it out. Now, probably, of the method used right now, this is probably the best alternative for women that for religious or organic reason cannot take the pill. Are there any other questions? Or what about our moderator?
Sorry I was late. If you have any questions that you would just soon write out, please do so and turn them in, and Dr. Guerrero will answer them next week. You said you're going to cover pathology primarily next.
Yeah. Next time we'll talk about the organic problems related to social life and medical problems at this
like abortion
age.
and so forth.
Yeah, right.
Okay.
Abortion and venereal diseases and so forth.
Are there any questions about this process whatsoever at this point? The only thing I wanted to say, beside the point, before we were going to start, and I wasn't here, was to expand on what I said last week relative to this, the experimental aspect of this course. You understand that. Well, one thing that we're going to want from you at the end of it is some idea, not with your name on it or anything, but just some written kind of idea as to whether you think this was worthwhile, whether it was something that you would like repeated, and also any ideas you have as to how it can be expanded or changed, or if you want a couple different teachers, you know, or whatever, material that you want covered that wasn't covered, or material that you want more adequately covered. So be thinking about that as we go through these for the last two, and as we go through the next 4 sessions. Any other?
Yes.
What are some of the other contraceptive devices used besides these?
Cool.
Well, there are many anticonceptive devices in the market. Again, we go to the pear shape. One of them is what they call the diaphragm. And this is a rubber top that the woman can insert in the tip of the cervix. Now this usually is not very safe because you will have to be fit very well, and this very seldom happens, and it can be dislodged during the sexual intercourse because of the trauma in the tip of the cervix. Now usually women use the diaphragm combined with some antiseptic jelly that or vaginal Dutch that they put right after the sexual intercourse to kill any of the sperm that can be still around in the vagina. So this give a fairly protection, but it's not very reliable. Then in the male there is a homologous device, I could say that is the condom, that is just a bag that the man can put over the penis, and in this way he avoids that during ejaculation any one of the sperm get into the cervix or the uterus of the woman. Now the problem with this is twofold. The first, that there can be a tear during the sexual relationship and nobody will be aware of this until it's too late. And then the other one is that in the withdrawal of the penis, there can be some spilling of the sperm in the cervix. Then another anticonceptive method, not a device, is a method. This will be a withdrawal before ejaculation, and I explained the problem about these two. Then we have the pills. There is abstinence. That is one. The price is very high, but it's 100% sure. And you don't need any medical prescription for that, although you may need the psychologist, the psychiatrist later. So next time we will go, we will study the problems that arise when this normal physiological base of sexual activity that we went over today has problems due to genetical aberrations or due to diseases. Mostly, yes?
What about the pill for men? I read an article on that.
Yeah, they are working on it, and I think that we're in the fact that males are the researchers. We probably would have had one long time ago. Yeah, there are some very encouraging reports, not only of pill for man, but there is a shot that is supposed to be effective for 3 months. So I think that in the future, this may be a scientific reality. I don't know how popular it's going to be. Then another thing that I forgot to mention is that one of the ways to avoid pregnancy, for example, is what you call sterilization. In women, usually this involves either hysterectomy, that usually done for not just sterilization purpose, but because of tumor or something. The usual procedure in women is to tie the fallopian tubes, and even this is not 100%. So much that I am in the sterilization committee of 2 hospitals, and we always make sure that when the woman and the husband sign the petition that they want, that he agree that she should be sterilized and she wants to be sterilized, we always make point that they say that they have been explained the procedure by the doctor, and they know that there are some rare cases of recurrence of pregnancy, even with this procedure. Now, in man, the sterilization procedure is mostly in the spermatic cord, the vasectomy. And in man, this procedure is usually very, very reliable and has the advantage that with further surgery can be corrected. 50% of them can become fertile again if they want to be. In women, this is not possible right now. Are there any more questions?
Yes, sir.
Does removal of the prostate in male have any effect upon sexual response?
No. There is a belief in some, there have been the common belief that it has to do something with decreasing the sexual desire or increasing it, but in the study that have been under good control, what they advise the doctor to tell the patient that is supposed to have a prostatectomy is that he will be the same before, during, and after. Any other question?
When I was young and before the pill, the statement always was the safest method of birth control was another pill, an aspirin held tightly between the knees. Are there any other questions? See you next week.